that is ketamine, my favorite medication in the world. And if you give ketamine at reasonably small doses in a sick patient, they will very rapidly dissociate. The doses we recommend, 1 milligram per kilogram, which sounds low. People might be used to higher doses. Try the 1 milligram per kilogram and see the response. You will see the full results of ketamine within one circulatory time, within seconds. So there's no reason to give huge doses because there's dose-dependent side effects to this medication, like hypersalivation. So give a milligram per kilogram of the ketamine. Wait a few seconds. The patient should fall back on the stretcher, eyes goggling back and forth, not fighting you at all anymore. If it doesn't, if that's not enough, give another 0.5 milligrams per kilogram. Wait a few seconds. Do it again if you need to. But eventually you'll get the patient to the point where they are dissociated. At this point, you could pre-oxygenate. You could denitrogenate. You could put an NG tube in if you want. You could do all the things you want to do to get ready calmly and safely. And only at that point, after the patient's denitrogenated for 3 minutes, after their saturations have come up, push your paralytic agent, give apneic oxygenation during the apneic period, and then intubate them safely with a buffer of oxygen as a reservoir in their lungs. Delayed sequence intubation is not CPAP pre-oxygenation. You don't need to put the patient on non-invasive or give them PEEP in order to be doing DSI. In fact, many of the patients in the study I'm going to show you in a minute actually they were saturating okay, but they wouldn't tolerate the non-rebreather mask in order to wash out the nitrogen of their lungs. So DSI is not CPAP pre-oxygenation, but DSI works beautifully with CPAP pre-oxygenation for patients who are physiologically shunted and their saturations are not coming up with the standard pre-oxygenation techniques like a non-rebreather mask. These four concepts are the things I've been talking about for years now, and they all work very nicely together. And we've belabored apneic oxygenation to the point you don't need to hear about it anymore. We're talking about DSI and CPAP pre-oxygenation right now, and using a ventilator as a better bag may be a topic for a future smack talk. So let's say on this patient, they're showing us that a non-rebreather is not enough to get their saturations up. How should we apply CPAP for pre-oxygenation? In the old days, I would have said just get a ventilator, have respiratory, keep ventilators in your resuscitation bay so that you could just immediately turn it on and put the patient on PEEP through the ventilator. But having actually road tested that with a host of people at many, many different institutions across the world, I realized that probably is not the safest way to go. It works beautifully, but it adds a level of technical expertise and possible error that's probably not worth it. I don't recommend that anymore. These CPAP devices, great, but you might not have them, you might not know how to use them. Don't do it. Grab a nasal cannula. If you're somewhere in the UK, you could grab a Mapleson circuit. I make my own, and all I say is get a PEEP valve. If you don't know what these are, your respiratory therapy department or your hospital stocks these. Every hospital in the world has these. They're dirt cheap, and they fit on the exhalation port of every BVM out there, and they allow you to dial in whatever PEEP you want. If you put a nasal cannula underneath the mask of that BVM with a PEEP valve, it becomes a high-flow CPAP device that will allow the patient to have whatever PEEP you dial in, regardless of whether they're breathing or not. So on a patient you're doing DSI on, put on a nasal cannula, grab a BVM, put a PEEP valve on it, and put that over the patient's face with a two-hand mask seal. And that's going to force you to do two things. One, it's going to force you to realize very quickly whether or not the patient needs PEEP, because you'll hold that mask on a PEEP of 0, look up, SAT's not coming up, dial it to 5, dial it to 10, dial it to 15. It'll also force you to be watching the patient the whole time you're doing delayed sequence intubation, because you're standing there right over them with two hands on their mask. And you don't have to squeeze this bag. Their spontaneous respirations, along with that nasal cannula, will do all the work for you. And so now all of a sudden the patient's getting 100% FiO2. They're getting whatever PEEP you dial in. They already have the nasal cannula on for their apneic oxygenation, and you're now watching them like a hawk because you're holding that mask over their face. This is how I recommend CPAP pre-oxygenation, and this is how I recommend DSI pre-oxygenation. So nasal cannula, BVM, PEEP valve. Put the nasal cannula at 15. The BVM has a PEEP valve. It could go anywhere up to 15 centimeters of water. And the BVM is on 15 liters of oxygen. So it's the rule of 15s coined by my friend Anton Hellman, and that's all you have to remember. Nasal cannula 15, BVM 15, both liters per minute, and a PEEP valve up to 15 centimeters of water. And this is the ideal pre-oxygenation device. Now, sometimes we use DSI even though the patient tolerates denitrogenation and their SATs are fine. And if you have a patient, cirrhotic, upper GI bleed, belly out to here, that's pretty risky to intubate that patient with a belly full of blood. And it works out very poorly once that lower esophageal sphincter starts opening up. It's an endless flood. And Jim might have some answers on what to do if you've already missed the boat and they're doing that. But it would be a lot nicer if you would just get an NG tube in and suck out the 2 liters of blood initially. And some of our patients who we use DSI on are actually simply because they won't tolerate me placing that NG tube. And so we give the ketamine, we place the NG tube, they get an insane amount of analgesia from that ketamine, and then we can pre-oxygenate them at the same time we're sucking out all that blood. All right, where's the evidence for delayed sequence intubation? I wrote a paper. Some of the authors are with me here. I don't know if Soren's here. I see Seth Truger here in the audience. But we actually looked at our patients who we were going to do DSI on, and we looked at this prospectively. 62 patients, all the reasons you'd expect for ED intubations, all the standard stuff. And the actual number of patients who were intubated for oxygenation was the vast majority. Some of them had ventilatory failure, and some of them had mental status changes, possible head injury. We just wanted to intubate them for airway protection. And a good portion of the patients were physiologically shunted. They actually couldn't get their saturations up with a non-rebreather, so they wouldn't tolerate non-invasive, so we gave the ketamine in order to allow them to take non-invasive ventilation. And here's the graph they had me put in the article. We can't interpret this. This is only for stat nerds. This is a lot easier to see. On the left side of the screen is the patient's initial saturations, and then on the right side of the screen is what happened after we gave the ketamine and pre-oxygenated the patient. And on the left, all those patients were with maximal attempts at trying to convince them to pre-oxygenate. And almost every patient increased their SAT. 2 patients dropped by 1 to 2% on their SATs. And this is not really the graph that I'm proud of. The one that really matters to me is this one. This subsetted out the patients whose initial saturation, despite maximal attempts,